sparing time for this presentation, and I would like to keep it at a very basic level, and I'll be happy to have interaction with all of you. If there are any questions, uh, whatever the organizers decide, either you can put the questions in the chat box, or if you want, you can interrupt me in between also. I don't mind either way. So I'm going to talk about an important topic of the role of radiation therapy in the management of extremity soft tissue sarcomas. So I'm going to tell you, share with you when to give radiation, how to give radiation, and which modality of radiation therapy has to be used when. So I'll try to keep it at this presentation at the level of postgraduates, so that the basic concepts about radiation therapy are clear. And as Dr. Navneet had informed me that majority of the audience are going to be radiation oncologists, so I have kept more material from the perspective of radiation oncologist rather than surgical or medical oncologist. So first of all, soft tissue sarcomas are not very common malignancies. They are rather rare malignancies or uncommon malignancies. They can occur in any part of the body, but still almost half of them, 50 to 60%, occur in the extremity. And they are generally grouped and labeled by the cell of origin, whether it is synovial cell sarcoma or a liposarcoma or a rhabdomyosarcoma. And sometimes the origin is not clearly known also. Sorry. Not a very common malignancy. Common malignancy that we see routinely in our practice includes breast cancers, head and neck cancers, lung cancers, GI cancers. Soft tissue sarcoma is one of the rare or uncommon malignancies. Now, it can occur in any part of the body, but majority still occur in the extremity, and they are grouped and labeled by their cell of origin. Although sometimes the origin is not known, but largely we call them liposarcomas, rhabdomyosarcomas, peripheral nerve sheath tumors, depending on whatever is their origin. Now, earlier, soft tissue sarcomas, even in the extremity, were treated with amputation. Now, we all know that amputation has largely been replaced with conservative surgery with or without postoperative or preoperative radiation therapy. The goal of treating any soft tissue sarcoma should be very clear. The goal is we want to maximize the local control rate. We want to maximize the survival of these patients. And we want to decrease the treatment-related morbidity so that at the end of the treatment, patient should be able to achieve an optimal functional limb. We don't want to preserve the limb for the sake of it. It should be a functional limb. And to achieve this goal of optimal limb function, both surgical techniques and radiation techniques are critical to achieve this goal. Now, as a radiation oncologist, we take pride in treating several malignancies. For example, in anal canal cancers, we've managed to give these patients colostomy-free survival. Or, for example, in seminomas, we know that we can cure these patients. Or vocal cord carcinomas, we can cure these patients. So, as a radiation oncologist, inherently we take a lot of pride in treating some of these malignancies, and so is the case of soft tissue sarcomas also. Now, in soft tissue sarcoma, once radiation-based therapy is added, one thing is that we can avoid amputation. Second is by giving radiation therapy to these patients, they get an absolute local control rate benefit ranging from 20 to 30%. So I think this ballpark figure of 20 to 30% is something which all radiation oncologists and surgical oncologists should be aware of. This is a broad figure that I would quote here. Whenever we are doing workup of any patient of soft tissue sarcoma, we certainly look for local imaging like MRI. We do biopsy, a planned biopsy is done, but we do workup in the form of CT chest or CT or MRI of the abdomen to look for any liver metastasis, lung metastasis, etc. But apart from that, I will say two other workups are very important. One is that one should be able to identify whether the patient is at a risk of increased wound complications, which means if the patient has any history of diabetes, I'm getting a message that my slides are not moving. So I think I will stop screen share and restart my screen share once again. Are my slides moving now?
Yes, ma'am.
So I was told that I was stuck at the slide number 2. Is this visible to you now?
Yes, ma'am. It's visible.
Okay. I'm really sorry for this technical problem from my end. So this is what I was telling you just now, that as a radiation oncologist, we must remember that addition of radiation therapy increases the local control rate by 20 to 30%. And the next thing that I was mentioning was about the workup. Whenever we are doing the workup, we must also assess whether the patient is at a risk of increased wound complications by virtue of having either diabetes mellitus or peripheral vascular disease or history of smoking or previous RT or surgery to the site of disease or baseline edema. So we must keep all these things in mind when we are taking a decision about patient's management in a multidisciplinary team. It is also critical to evaluate the limb function before surgery itself. For example, if somebody already has a joint problem, then the limb function may not be optimal even after surgery and radiation therapy. These things should also be evaluated and noted down somewhere in the workup of these patients. Another thing is that we must do a nodal evaluation, which is commonly done for synovial sarcomas, clear cell sarcomas, angiosarcomas, rhabdomyosarcomas, and epithelioid sarcomas. For example, if we get a patient of angiosarcoma, which is there in the lower limb, then we would generally ask for ultrasound of the inguinal and pelvic region to identify any nodal basins, any nodes in these areas. And clinically also one must examine these draining sites like popliteal lymph nodes and inguinal lymph nodes, etc. So this is the basic layout of my presentation today. I'm going to talk about when radiation therapy is indicated, how much dose and how much margin and volume, etc. is required, which modality has to be used, conventional, brachytherapy, IMRT, etc., complications of radiation therapy, and then in the end, I'm going to talk in detail about the practical tips of performing brachytherapy at a level of postgraduates. So surgery alone can be a treatment. So the first question that I'm trying to answer for all of you is, when is the role of radiation therapy? So it is very easy. Surgery alone can be used in the management of soft tissue sarcoma only when the tumor is less than 5 centimeter. It is a small tumor. It is low grade and superficial, and it is widely excised with acceptable margins. The margins, recommended margins, are margin of more than 1 centimeter, 1 or more centimeter, or less if there is an intervening facial barrier which is already present. And ideally, the surgical plane should traverse the normal tissue outside the reactive tumor zone. So, except for this small subset where the tumor is small and low grade and superficial and widely excised, all other patients practically would require radiation therapy. So what I mean by that is that if a patient has a tumor, say measuring 7, 8, 10 centimeter, even if it is low grade, then these patients would require adjuvant radiation therapy. Or even if the tumor is small, but it is deep seated where the resections become more difficult, then these patients are preferably treated with radiation therapy. And all high grade sarcomas, irrespective of whether they are superficial or deep, irrespective of their tumor size, would also benefit with adjuvant radiation therapy. Now, when I said that low-grade small superficial sarcomas can be managed with surgery alone, the evidence for this comes actually from the retrospective study from the Dana-Farber, where 74 patients with soft tissue sarcomas of trunk and extremity with small median tumor size of 4 centimeter were treated with surgery alone, and the 10-year local control rate in these patients was 93%. So this is the only study which gave us confidence that this is the subset of patients who do not require radiation therapy. Now, as a part of your postgraduate curriculum, you must remember this landmark practice changing paper, as I call it, which was published in 1982. This was a NCI randomized trial done by Rosenberg et al., where patients of soft tissue sarcoma were randomized to amputation versus wide local excision with postoperative radiation therapy. Now, in this study, they showed that the local recurrence was higher in the arm receiving wide local excision and radiation therapy. It was about 15% versus it was only 0% in the amputation arm, but the overall survival was same. So this is the trial of small number of patients which changed the entire management of soft tissue sarcomas, and the management moved from amputation to wide local excision. Dr. Navneet, I hope I am clear to all of you and I am audible and my slides are moving.
Yes, ma'am.
Okay, thank you so much. Now, when I say that this is a practice-changing trial, which all of us must remember and know about in detail. Now, when I say to you that post-operative radiation therapy is required for all high-grade sarcomas or low-grade sarcomas, I'm going to present to you two level 1 evidences which are there in favor of adding post-operative radiation therapy and not treating these patients with surgery alone. This is another landmark trial which all of us should know. This was the principal investigator for this trial was Yang et al. It was published in JCO long time back, where the patients were randomized to surgery alone versus surgery followed by post-operative radiation therapy. And here, surgery meant wide local excision with 1 to 2 centimeter margins. And most importantly, the 10-year local recurrence rates of this study are now available. So all the patients had surgery, all the patients got chemotherapy, and the randomization was post-op RT versus no post-op RT. This was a small study including about 150 patients. There were 91 patients of high-grade sarcomas, and with the addition of radiation therapy, the 10-year local recurrence rate in these patients was 0%, as compared to without post-operative radiation therapy, it was 22%. So, and the p-value was significant. Now, even in the low-grade sarcomas, addition of radiation therapy, after addition of radiation therapy, there were 4% local recurrence rate as compared to 33% without addition of post-operative radiation therapy. So this landmark trial showed to us that radiation therapy definitely improves local recurrence amongst both low-grade sarcomas and high-grade sarcomas. And this study also did a prospective evaluation of quality of life of these patients. Sarika, please stop it. These patients who were treated with radiation therapy had increased edema. They had worse range of joint motion, decreased limb strength, etc. They had radiation therapy related side effects, but overall there was no difference in the global quality of life of these patients. Now, further updated follow-up of about 18 years is available for these patients, and none of the patients in the high-grade sarcoma group who were treated with radiation therapy developed a local recurrence even after a median follow-up of 17.9 years. This follow-up was taken on a telephonic basis. And patients receiving on a longer follow-up, they found that patients who had received radiation therapy actually had better overall survival. It was 64% in the surgical arm, 71% in the arm receiving post-operative radiation therapy, although the difference in the overall survival was not statistically significant, but there was a 7% improvement even in the overall survival of the patients who were treated with post-operative radiation therapy. Now, another level 1 evidence or the randomized trial, which is available, came in 1993, where patients after wide local excision were randomized into two arms by giving addition of brachytherapy versus no brachytherapy. Again, this trial also included about 150 patients, high-grade sarcomas as well as low-grade sarcomas. And this also showed that there was an improvement in the local recurrences, decreased to 9% with addition of brachytherapy as compared to wide local excision, where it was 30% in the high-grade arm. And in the low-grade arm, there was no statistical difference in the local recurrence rate with or without addition of brachytherapy. So if I have to summarize, I have told you three important trials which all of us have to remember. First is the trial by Rosenberg et al., which came in 1982, comparing amputation versus wide local excision with radiation therapy. Second, when wide local excision was and radiation therapy was successful, people thought, is there a need of radiation? So again, there were two randomized trials. One added postoperative external beam radiation therapy, and the second trial added postoperative brachytherapy. And both these trials, second and the third trial, showed there was a significant difference in the local recurrence rate with the addition of radiation therapy, either in the form of external RT or brachytherapy. So whosoever is practicing soft tissue sarcoma treatment must know these three very important trials. Now, apart from these randomized trials, there is also a systematic review which is available, which has looked at all the studies of adjuvant radiation therapy in soft tissue sarcoma, which included 5 randomized trials, 6 prospective and 25 retrospective studies, overall including 4,500 patients, large number of patients. Now, this systematic review also showed that adjuvant radiation therapy improved local control in soft tissue sarcomas of extremity and trunk in patients even with negative margin or minimal microscopic positive cut margin. And generally, overall local control rate with addition of radiation therapy was around 90%. Going further, at times in your multidisciplinary team, when you're sitting and when you have a discussion about management of a patient, a lot of surgical oncologists and MSK surgeons would tell you that you are only impacting the local control rate and adjuvant radiation therapy does not impact survival. Well, we do not have level 1 evidence, but then there is a SEER database of around 6,960 patients where they looked at the impact of adjuvant radiation therapy on overall survival. In low-grade sarcoma, they found that addition of radiation therapy did not change survival because these tumors are generally low-grade. Probably that is the reason. But in high-grade sarcomas, especially for large high-grade sarcomas, addition of radiation therapy has also been shown to improve overall survival. So what else do you want? You want to conserve the limb, you are able to do that. You don't want to have a lot of local recurrences, you are achieving that. The third thing that you want to achieve is the improvement in the overall survival. That also we are able to achieve with addition of adjuvant radiation therapy. So dear friends, the only point that I'm trying to emphasize and re-emphasize is that radiation therapy is an essential component of sarcoma treatment. So if I have to summarize when to add postoperative radiation therapy, I would say that any feature by virtue of which you think that your patient is at a higher risk of local recurrence after surgical resection alone. For example, a tumor which is large, more than 5 centimeter, or a lesion which is deep-seated or is invading the superficial fascia, or a high-grade tumor, or narrow or positive surgical margins, or patients who've already had a local recurrences, all these patients must get postoperative radiation therapy. Now, I'm going to slightly change the gears here and talk about the preoperative radiation therapy. So honestly, all of us have our own biases. As a radiation oncologist, I am very biased. Am I audible to you or not?
Yes, ma'am, you're audible.
Okay, thank you. So there is a controversy about optimal sequencing of radiation therapy. Radiation therapy can be added with surgery either preoperatively or postoperatively. Now, both preoperative and postoperative radiation therapy have their advantages and disadvantages. Now, if I have to summarize them, then I will say that preoperative radiation therapy has to be given in the lower dose. The dose is around 50 gray, whereas in postoperative radiation therapy, the dose is higher. It is in the range of 60 to 66 gray. Now, because in the pre-op party, the tumor is intact, our field sizes are small. In postoperative radiation therapy, where we are chasing the post-op surgical flaps, scar, etc., our field sizes are large. Now, because in preoperative radiation therapy, dose is less, volume irradiated is smaller, definitely there is reduced fibrosis, reduced edema, while in postoperative radiation therapy, both these complications increase. But the caveat is that with the addition of preoperative radiation therapy followed by surgery, the wound complication rates increase and they are actually just double of the wound complication rate which occurs after postoperative radiation therapy. Now, all these issues, all these points we have learned from this very, very important randomized trial. This trial came from NCI Canada. The principal investigator of this trial is Brian O'Sullivan. So as a radiation oncologist, whosoever is practicing sarcoma treatment must know this trial very well. So this trial had approximately 200 patients, and these patients were randomized into two arms. Arm 1 was treated with preoperative radiation therapy to a dose of 50 gray in 25 fractions followed by surgery, with or without postoperative boost depending on if the margins were positive. And in the second arm, The patients were treated with surgery followed by postoperative RT in the dose of 60 to 66. Sorry. The primary endpoint of this trial was wound complication at the end of 120 days, and the secondary endpoint for this trial were local control rate and overall survival. Trial where patients were randomized, soft tissue sarcoma patients were randomized into two arms. Close to 200 patients were there in this trial, and I will say this is one of its kind trials. These kind of trials are very sparingly available for other sites. So in this trial, the patients were randomized into two arms, preoperative radiation therapy followed by surgery versus postoperative radiation therapy. And as you can see here, the dose of the preoperative radiation therapy was only 50 gray in 25 fractions. And postoperative radiation therapy boost was added to a dose of 16 to 20 gray only in patients who had positive margins. While the dose of postoperative radiation therapy in this study was 60 to 66 gray. Surprisingly, the primary endpoint of this study was wound complication at 120 days, and probably that is the reason that they could manage this trial with 200 small number of patients. The secondary endpoint, however, were local control rate and overall survival. Now, if you look at the outcome or the results of this trial showed that the 7-year local control rate between the arm receiving preoperative RT versus postoperative RT were exactly similar. There was no difference. But if you look at the primary endpoint of the study, which was wound complications, the wound complication rate was double in the arm receiving preoperative RT as compared to postoperative RT. So which means I'm trying to say that the wound complication rate was higher in the preoperative arm. But now let's look at the other aspect. The other aspect is late toxicity. So if you look at late grade 2 to 4 toxicity, any toxicity, it was less in the preoperative arm and was higher in the postoperative arm for the simple reason that in the postop RT arm, the radiation dose is higher, the volumes are bigger. If you look at the grade 3, grade 4 subcutaneous toxicity, in the preoperative arm, it was 23% versus it was 68% in the postoperative arm. So the control rate is similar. In preoperative arm, the acute complications are higher, and in the postoperative arm, the late complications were higher, much higher. Now, if we look at the wound complication rate by the site, then we find that in the upper extremity patients, the wound complication rate was only 5.5% with preoperative RT and 0% with post-op RT. In the lower extremity, it was 43% with preoperative RT and 21% with postoperative RT. So the same dose of preoperative RT of 50 gray was producing different rate of wound complications in different sites. So as a radiation oncologist, if I have to counsel my patient about preoperative RT versus postoperative RT, I generally look at two factors. If it is upper extremity, then I'm more and more inclined towards preoperative RT as compared to postoperative radiation therapy, because I know that I'm not going to increase the wound complications to much higher rate. And the second thing which I often use with my patients is that I ask them whether you are willing to have more acute complications or are you willing to have more lifelong complications. So that is how I look at this trial. But I know that a lot of my surgical oncology colleagues, even in my MDT, do not agree with this kind of counseling. But I think this is what the results showed. Now, apart from this also, there are several, this randomized trial, there are several other studies also. These are all retrospective small studies which have all consistently shown that the wound complication rate is higher with the use of preoperative radiation therapy. But I believe, although it is only a belief that these pre-op, once we know that these patients are at a higher risk of wound complications when we are giving them preoperative radiation therapy, what we can do is that we can use more conformal RT to decrease the skin and the subcutaneous dose. And we would always want that our surgeons should not do wound closure in tension and avoid any primary closure. Rather, they should, the wound which is closed should be done not by primary closure, but by using some myocutaneous flaps, either pedicled or free flap from the non-irradiated areas. We must keep drains for sufficient time. We must gently handle the tissues during surgery, and post-operative wounds must be avoided as much as possible. For example, look at this picture. This was operated by one of our sarcoma surgical oncologists, and this patient had a sarcoma of the arm. And instead of doing a primary closure, which would have led to a lot of contracture, fibrosis, etc., he's put a nice flap over there so that there will be no tension and no issues of wound healing, etc. So I think if once we are aware, in this time and era, wound complications should not be a major deterrent by because of which we are not able to use preoperative radiation therapy. Now, going further, I will show you the National Oncology Database also, which had 821 patients with extremity and non-extremity sarcomas, which were treated with either preoperative or postoperative radiation therapy. And 60% patients had negative cut margin, and 17% patients received chemotherapy also. Now, this National Cancer Database showed that as compared to when we compare preoperative versus postoperative radiation therapy, the local control rates are better with the use of preoperative radiation therapy as opposed to postoperative radiation therapy. And also, there is a survival advantage with the use of preoperative radiation therapy as compared to postoperative radiation therapy. So the 5-year overall survival in the preoperative arm was 65% as opposed to 60% in the postoperative arm. This cause-specific survival was definitely much superior in the two subtypes of sarcomas. One is synovial sarcoma and the other is leiomyosarcoma. Probably the NCI Canada trial could not show this survival advantage because the number of patients in that study were inadequate. The study was not adequately powered to show the difference in the overall survival. So earlier also, when I was talking about post-operative radiation therapy, I emphasized that we get two gains by adding radiation therapy, adjuvant radiation therapy. One is improvement in control rate. The second is improvement in the overall survival by either in the preoperative or post-operative setting. And but somehow preoperative radiation therapy has not taken off well. And this is a graph which is showing the number of percentage of patients who are treated with preoperative radiation therapy across USA. And if you look at this from 1988 to 2006, the numbers have almost remained stable. And somehow, I think this is not very well acceptable to our surgical colleagues. So now I will come to another aspect of radiation therapy. I'm going to answer this question of timing of postoperative radiation therapy. In India, we treat a lot of head and neck cancers and cervical cancers, where as a radiation oncologist, we are very conscientious about the overall treatment time. But when it comes to malignancies like sarcomas, we often forget and we are not sure how much time is optimum from surgery to the start of radiation therapy. This is a small study where it showed that patients who were treated with postoperative radiation therapy within or after 4 months of surgery, and they compared the 5-year relapse-free survival. And this study clearly showed that patients who were treated with radiation therapy starting within 4 months of surgery had a superior relapse-free survival as compared to the patients who got radiation therapy at a much later time point. So I will summarize whatever I have spoken till now. I have tried to answer this question, when to give radiation therapy. So first of all, indication of postoperative radiation therapy: all high-grade tumors, large or marginally excised low-grade sarcomas have to be treated with postoperative radiation therapy. If we compare pre-op-RT versus post-op-RT, pre-op-RT gives better long-term functional outcome, equivalent local control rate, although it comes at the cost of increased wound complication rate, but somehow it is still not widely practiced. If you're adding postoperative radiation therapy, I recommend that one should start postoperative radiation therapy as early as possible after the wound healing, preferably within 4 to 6 weeks from the date of surgery. So now I'm coming to the second question of my presentation: which modality of radiation therapy has to be used? We have limited modalities. One is brachytherapy and the other is external beam radiation therapy. Now, brachytherapy, which we do at the time of surgery, is called as perioperative brachytherapy. It is generally not called as intraoperative brachytherapy. The difference between true intraop brachytherapy and perioperative brachytherapy is that when we lay down the interstitial catheters at the time of surgery, but give radiation therapy in subsequent coming days, then it is called as brachytherapy. In a true intraop brachytherapy, the radiation therapy is given right on the OT table. That is true intraop radiation therapy. So in perioperative brachytherapy, if somebody asks you this question, we do the procedure intraoperatively, but the treatment is done in the perioperative time period. The second option that we have for giving radiation therapy is external beam radiation therapy. There are several techniques of giving external beam radiation therapy. It can be given by conventional mode, 3D conformal radiation therapy, IMRT with or without image guidance, and now we also have proton therapy available for delivery of radiation therapy. At times, we use combination of EBRT and brachytherapy also. So this is a picture which is showing that there are intraoperatively, after the surgical excision of the tumor is done, nylon brachytherapy catheters are placed in the tumor bed or in the target areas, and then the wound is closed, and then the radiation therapy is usually started 4 to 5 days after from the day of surgery. Now, we as the student of radiation fraternity, we all know that brachytherapy is probably the highest or the most conformal form of radiation therapy. It is even superior to any form of carbon ion therapy or proton therapy. So this picture is actually showing you a CT picture. This is the bone. This is probably femur. This is the sarcoma brachytherapy dose distribution. These red dots are representing the catheter. This blue is the target volume, and this is showing the dose distribution. So you can very well see here that the dose is confined only in the single slice of the tissue which is forming the tumor bed. So as a result, we are able to give a very conformal dose of radiation therapy with maximal sparing of surrounding tissues like this subcutaneous tissue, skin, muscles, the rest of the circumference of the limb and the bone, etc., which means the patients will have much lesser side effects even in the long term with the use of brachytherapy. Brachytherapy has another advantage. Brachytherapy has a built-in simultaneously integrated boost. For example, the area which is in the immediate vicinity of the catheter. This red dot is representing the catheter and the position of the source. That gets something like 200 or 300% dose. While at the 5 millimeter, you will get something like 100% or 90% dose. So there is a built-in SIV which is always there in the brachytherapy. Brachytherapy is definitely radiobiologically better. It is a shorter and convenient time and is associated with much lesser rate of complications. For example, the wound complication rate is 2 to 14%. If we talk about chronic bone injury, which means the fracture, I'll be coming about it later on also, it is 0 to 4%. If we talk of chronic nerve injury, then it is about 0 to 10%. So the complication rate is far lesser. The limitations of brachytherapy is that we cannot apply this technique of radiation therapy if our target volume is very big. For example, suppose you get a soft tissue sarcoma, which is measuring about 15 centimeter in lower limb, then you may not be very comfortable doing brachytherapy because once the volume becomes larger, then you cannot maintain the symmetry of your catheter placement. So for a very large volume, brachytherapy is sometimes not useful. The second limitation of brachytherapy is that you might have a tumor at the site where sometimes you might not be able to place the catheters well, either because of bone or visceral organs. For example, suppose you have a tumor in the upper medial aspect of the thigh and you're not able to place your catheters because there is inguinal ligament, there is pubic bone, etc. So you might have these kind of limitations in performing brachytherapy. Now, brachytherapy, as I mentioned just now, can be used either as monotherapy, which means only brachytherapy, or we can use it in combination with external beam radiation therapy. Now, the indications of using brachytherapy alone as monotherapy are: once you have a high-grade lesion with complete surgical excision and negative margins, and in a region where you can place your brachytherapy catheters well, and usually the tumors which are chosen for brachytherapy as monotherapy are less than or up to 10 centimeters in size. Any pediatric sarcoma, brachytherapy is always preferred over external beam radiation therapy because we would like to decrease the dose to the OARs as much as possible. The another indication for brachytherapy is in the previously irradiated sites. If there is a local recurrence, you would always prefer to use brachytherapy instead of external beam radiation therapy. Now these are some of the series where a lot of LDR or HDR or PDR-based brachytherapy has been used in various dose and fractionation. And all these studies have reasonable amount of follow-up also. And if we look at generally, the local control rate with the use of brachytherapy is up in the tune of 80 to 90%. And the complication rates are ranging from 0 to 15%. There are times when we use brachytherapy as a boost. So the indication of using brachytherapy as boost are where you cannot do brachytherapy as monotherapy. For example, when your target volume is very large, or you think that you cannot adequately cover your target volume with brachytherapy alone. For example, atypical geometry, skin ulceration, etc. Or if you think that patients have a high risk of recurrence, which means the tumor size are big, more than 10 centimeter, or positive margins, or recurrent disease, there one can combine EBRT and brachytherapy both. Dear friends, the point that I'm trying to emphasize here is that whenever you get a chance to do brachytherapy, always try and do brachytherapy, intraoperative interstitial brachytherapy for all soft tissue sarcoma patients. Whether you do it as boost or radical brachytherapy does not matter. But whenever you're doing brachytherapy, you will increase their local control rate as well as decrease their complication rate. Now, this is a small study from MD Anderson by Andrews et al. It is a retrospective study of around 86 patients who were treated with either a combination of EBRT and brachytherapy or EBRT alone. The radiation therapy doses which were used were EBRT alone was approximately 60 gray, and in the EBRT and brachytherapy, external RT was 50 gray and 16 gray was delivered with LDR brachytherapy. Now, the 5-year local control rate were 100% in the arm receiving EBRT and brachytherapy as opposed to 60% in EBRT alone arm. And for the high-grade sarcoma specifically, the 5-year local control rate was 100% as opposed to 74% with EBRT alone. Because we must remember that when you're doing intraoperative brachytherapy, you're absolutely sure about your target also. You can never do a geographical miss. In EBRT, whatever you may do, CT, MRI, surgical flips, you might still miss some target. Secondly, when we are saying that we gave 16 gray by LDR, the 16 gray has gone to 0.5 centimeter from the position of the catheter. But in the immediate vicinity of the catheter, the dose would have been much higher, maybe 32 gray or 48 gray. So whenever one gets a chance, one must do brachytherapy for these patients. And I'll tell you from my own experience, brachytherapy for soft tissue sarcoma is probably the simplest form of brachytherapy. It increases your confidence to do brachytherapy because it is generally a single plane implant. The surgical wound is well open in front of your eyes as compared to when you're doing brachytherapy in head and neck cases, tongue, buccal mucosa, where it is far more complicated and requires much more experience to do that brachytherapy, while this brachytherapy is much more simpler. Now, this table is showing multiple series. I would like to point out here, this also has a series published from TMH in 1998, where the patients were treated with combination of EBRT and local LDR brachytherapy. EBRT doses were 45 gray, and there is a follow-up of around 40 months, and the local control rate in this was 71% with a complication rate of less than 1%. So several series have shown that combination of EBRT and brachytherapy also works well for these patients. I think this I have almost talked about, that even when we are using brachytherapy as boost, there are several advantages. One is you cannot have a geographical miss. Second is radiation therapy starts earlier. It starts in almost 4 to 5 days time. So, before the tumor cells get a chance for repopulation, radiation therapy is already started. In the perioperative period, the tissue is better vascularized. There is less fibrosis. So radiation therapy is far more effective. Then there is SIB also. Now coming to the second modality of radiation therapy, which is by external beam radiation therapy. So here radiation therapy can be given either with conventional technique. We all have used conventional technique for soft tissue sarcoma management for a long time because there are much lesser critical organs in the vicinity of extremity sarcomas. The critical organs that you have are soft tissue or bone or skin. Apart from that, you do not have any visceral organs. So conventionally, we have all treated these patients with either APPA fields or bilateral fields. And we have always been taught that we have to spare the lymphatic corridor, which means we should never be treating the entire circumference of the limb. We should be able to spare some area of the limb circumference where there is practically no radiation, so that the lymphatic flow continues and these patients have a lesser chances of getting lymphedema. And while the excellent local control rates are preserved, the overall complication rate of external beam radiation therapy with conventional techniques are that about 10 to 20% of the patients get edema. Fibrosis occurs in 30 to 60% patients. The bone fracture rates is about 0.7 to 7%, and there can be some decrease in the range of motion. So whenever you're doing conventional radiation therapy, I know Dr. Navneet Agrawal is from BHU. I'm sure you must be doing APP or bilateral very often for your soft tissue sarcoma patients, which is perfectly okay to do that. The only thing that I would like to emphasize is that one must pay attention to optimum positioning of the extremity. For example, suppose you have a lesion in the medial aspect of thigh, then you must put the thigh in the hip abduction and knee flexion position. Try to retract the genitalia on the opposite side. Pay attention to all these positioning maneuvers, which will help you spare the lymphatic corridor in these patients. And at the same time, your position should be reproducible. Another position could be, suppose you have a tumor in the anterior aspect of the leg and you want to treat this patient with bilateral fields, then you want to spare the posterior compartment of the leg. So it is a good idea to raise the affected limb on a styrofoam sheet and then give bilateral fields so that you can spare the posterior compartment as well as the opposite leg. So these are a few positioning tricks which all of us get learn during our post graduation and which are very helpful in doing the conventional radiation therapy well. Now, in the era of 3D CRT and IMRT, we initially had the evidence to use IMRT for head and neck cancers. Gradually, we moved to lung cancers, prostate cancers. Now, gradually, we also have a lot of evidence for using 3D CRT and IMRT even in the extremity and non-extremity soft tissue sarcomas. The advantages of using these conformal techniques is that you can confirm the dose to the desired target volume and you can spare the surrounding tissues well. For example, if you're treating this part of the soft tissue sarcoma, this part of the limb can be very well spared. And you can avoid a lot of hotspots also, so that there is less dose inhomogeneity and less side effects to these patients. So gradually 3D CRT and IMRT have taken a position even in the management of soft tissue sarcomas. This is a small study which came from MSKCC by Electiar et al., where initially they treated 41 patients, small number of patients were treated with surgery and IMRT. And all these patients had a lot of adverse factors, and that is why they were chosen for this study. For example, the tumor size was more than 10 centimeters in about 68% patients. The tumor was located deeply in 90% patients. There was positive cut margin in 5 patients, 5 out of 41, which is a good number. And there was close margin of about less than 1 millimeter in 16 patients. And that is why these patients were treated with surgery followed by IMRT. The radiation IMRT dose which was used, median dose was 63 gray, ranging from almost 60 to 66 gray. Now, they found that 5-year local control rate was 94% for patients, even when they had positive or negative margins. 94% control rate is a very good control rate for these patients, considering that majority of these patients, as I showed in the previous slides, had a lot of high risk factors like large size, deep location, or positive and close margin. Now, they also found that the grade 1 and 2 non-infectious wound complications were about 10%. For example, grade 1 and 2 bone fractures were 4.8%. Grade 1 and 2 joint stiffness was seen in 46% patients. Grade 1 and 2 edema occurred in about 1/3 of the patients. Grade 1 and 2 neuropathy occurred in 26.7% of the patients. There were no grade 3 and grade 4 complications. So this was the first study which came from MSKCC of only 40 patients, which showed that even in high-risk patients after surgery, IMRT could do a good job, high control rate and with very less complication. Now, the same group also did a retrospective analysis of IMRT versus brachytherapy for their patients, and they found that the control rate, local control rate was higher with IMRT as compared to brachytherapy, despite a lot more high-risk patients in the IMRT arm. I am not trying to persuade all of you to follow IMRT. I am not at all trying to put that point across. I would say that when you have to choose a modality depending on the availability of expertise and facilities. we have much longer results of brachytherapy and much more experience of using perioperative brachytherapy for soft tissue sarcomas, and we must continue to use that. It is still the preferred modality. What is important is to treat your patients well and choose a modality of radiation therapy depending on the facilities and the expertise, whatever is available at the end, wherever you're treating your patients. But I just wanted to highlight this option of using brachytherapy, external beam RT with either conventional or IMRT. Now I will come to another question of margins. Traditionally, we all have been taught that for soft tissue sarcomas, we have to give a minimum margin of 5 centimeter, including PTV, in the craniocaudal direction, while all around our margins can be around 2 centimeter. Now, this is one of the studies which was published by A.J. Mund et al. In 1995 in Red Journal, where they showed that the 5-year local control rate when the margins were less than 5 centimeter was only 30%, as opposed to margins of more than 5 centimeter where the local control rate was 93%. And this study is the genesis or the basis of our using 5 centimeter margin across majority soft tissue sarcomas. This is actually in slight contradiction to brachytherapy, where generally 2 centimeter margin is considered adequate. There is a prospective trial also which has addressed the issue of margins and have used the margin of about 2 centimeter. But in my own understanding, I think this margin of 5 centimeter is required for several reasons in external beam radiation therapy. And one of the reasons is geographical uncertainty. When you're doing intraoperative radiation therapy, you are right in the OT. In front of you, the surgical specimen comes out, you mark the surgical cavity, the clips do not have a chance to migrate, and so you are spot on. So probably that is the reason why 2 centimeter margin in brachytherapy is good enough. While probably the 5 centimeter margin is in the external beam radiation therapy is also because of uncertainty of location of the tumor. Another reason for this 5 centimeter margin is a study which correlated MRI and pathological specimens of soft tissue sarcoma patients. So this is a small study of 15 patients where they correlated MRI with histopathology in patients who were treated with upfront surgery. And they found that in 10 out of 15 cases, sarcoma cells were identified in tissues much beyond the tumor. In 6 out of these 10 patients, the tumor cells were located within 1 centimeter of the tumor. And in 4 patients, the tumor cells were located as far as 4 centimeter away from the tumor. So this is another genesis or rationale for using a margin of approximately 5 centimeter in external beam radiation therapy. I want to give you a word of caution here that we still do not have a deeper understanding of the margin and the doses which are required pertaining to a specific histopathological subtype of soft tissue sarcoma. So there is a histopathological subtype of sarcoma which is called as myxofibrosarcoma. It was earlier called as myxoid variant of MFH. In 2002, it got a separate name as myxofibrosarcoma. This tumor has been shown to have much more infiltrative borders. And in spite of treating with surgery and radiation therapy, they have a higher rate of local recurrences. And there are studies which have shown that majority of the recurrences, they occur outside the primary tumor bed, and probably 5 centimeter margins are also not enough for this myxofibrosarcoma. And these tumors usually require the recommended margin is up to 6 to 7 centimeter for patients with myxofibrosarcoma. There's another small point which I missed when I was talking about this study by Mund et al. Of 5 centimeter margin. Recently, there is a randomized trial which is called as Vortex trial, which has looked at the margins of 2 centimeter versus 5 centimeter in treating sarcomas with postoperative radiation therapy. And irrespective of 2 centimeter versus 5 centimeter margins, the local control rate was similar in both the arms. However, they have although the early results of this trial are now available, the authors of this study have recommended that we still stick to a margin of 5 centimeter till long-term results of this study are available. So for my exam-going colleagues, I would say that if the examiner asks you this question of margins, we still stick to the margin of 4 to 5 centimeter in spite of using the conformal techniques in these patients. This is another very interesting paper by Brian O'Sullivan. It came in Red Journal in 2012. It is a worth reading paper, especially for anyone who wants to practice conformal radiation therapy. Even if you don't want to practice conformal radiation therapy, please go through this paper. The Brian Sullivan is the same person who has done the randomized trial of preoperative radiation therapy versus postoperative operative RT NCI Canadian trial. So in this study, in this paper, they have given certain recommendations for contouring of CTV, identifying the CTV. For preoperative radiation therapy, they have recommended that the CTV should include GTV, gross tumor volume, with 1.5 centimeter radial margin and 4 centimeter craniocaudal margin. Radially, this white part is showing the gross tumor volume. This gray area is showing the edema, and this line is showing the CTV. And while this is representing the bone, so radially, the CTV need not be extended beyond the fascia that you can identify, or it may not ride over the bone. But the peritumoral edema across the tumor or craniocaudally has to be covered. So suppose you have given a craniocaudal margin of 4 centimeter, but then there is an edema which is extending 2 centimeters beyond that 4 centimeter margin. You have to extend and make your margin to about 6 centimeters to include the peritumoral edema. Now, if you want to identify this peritumoral edema, then you need an MRI. On CT scans, sometimes, rather majority of the times, you may not be able to identify this peritumoral edema. While for postoperative radiation therapy, they have given a different set of contouring guidelines. For phase 1, we construct the preoperative GTV using the information from the clinical notes, intraoperative notes, and the preoperative MRI. And the CTV phase 1 is again 1.5 centimeter margin radially and 4 centimeter craniocaudal margins. We extend this CTV margin to include all the visible clips, brain sites, and the surgical sites. And radially, we need not extend on the bone or across the fascia. And phase 2 is same as phase 1, except that it is only 2 centimeter margin around GTV craniocaudally, 1.5 centimeter radially. Now in this picture, if you can appreciate, he has also shown that you need to place the bolus along the scar. So there is a wire which has been placed along the scar, and we need to cover this with bolus. We generally, when we are giving postoperative radiation therapy, we use bolus for about 2/3 of the radiation. So we use bolus up to 40 gray of radiation therapy when we are giving 60 or 66 gray of total radiation therapy. Now, whenever you're planning radiation therapy by any of the techniques, either conformal or conventional, we have to always spare the lymphatic corridor. We have to make sure that the entire joint space is not included. We have to avoid full dose of radiation therapy to adjacent bone to reduce the risk of pathological fracture. We must include the screen and the drain site, at least in phase 1, and use wedges and tissue compensators or conformal IMRT like techniques to minimize the dose heterogeneity. Is this going okay?
Yes, ma'am.
So now I'll be talking about the doses of radiation therapy. So when we look at the dose response relationship for postoperative radiation therapy in sarcoma, there are studies which have shown that the local control rates are inferior for patients who receive any dose which is less than 60 gray. But there is not much dose response relationship beyond 60 to 66 gray. And in fact, our late sequelae, they increase much more as the dose escalates. So in a phased manner, the total dose which is recommended is for a R0 resection, the dose postoperative dose recommended is 60 gray. For R1, it is 64 to 66 gray. And for R2, it is 66 to 70 gray. Now, this recommendation came from the Munn paper in 1995. I again want to emphasize that I'm not suggesting that we give 60 gray to the entire 5 centimeter margin. We generally give 44 gray in phase 1 to a 5 centimeter margin and then phone down to 2 centimeter margin and take it up to 60 gray. Suppose there is a R2 resection, you may just give that additional 6 to 10 gray only to the site of R2 resection and not to a larger volume. Otherwise, the late complications as well as acute complications will increase to much more. In the preoperative radiation therapy, the standard recommendation is to give 50 gray at 1.8 to 2 gray per fraction. Please make sure we are not giving any concurrent chemotherapy in the preoperative radiation therapy. As radiation oncologists, we are used to using preoperative CTRT in head and neck cancers and cervical malignancies a lot. The same principles do not hold true here. There are a couple of case reports where people have given very low dose of adriamycin or cyclophosphamide and have burned their fingers, and the patients had acute complications, acute skin complications, and a good majority could not even complete preoperative radiation therapy. So when we say operative radiation therapy, it is only preoperative radiation therapy. It is not concurrent CTRT. I would also like to mention about the brachytherapy doses here. There are several dose fractionation which are available. We generally use 3 to 4 gray per fractions in 10 to 12 fractions total. So how do I choose between 3 gray and 4 gray per fraction is that if I have a smaller soft tissue sarcoma brachytherapy volume, then I'm okay to use 4 gray. But if I'm treating a volume measuring 10, 12, 14 centimeter, then usually the dose per fraction will be 3 gray given over 12 fractions over 6 days to a total dose of 36 gray. When you're combining brachytherapy with EBRT of 45 to 50 gray, then certainly the doses of brachytherapy will come down to 12 to 15 to 20 gray at the rate 3 gray to 4 gray per fraction, because you're giving a lot of dose with EBRT also. Is it going okay for all of you?
Yes, ma'am.
So the problem in the webinar is that you do not see the other side of the audience. So sometimes you feel whether you're audible or not. So if things are not going fine, please just let me know.
Sure, it's going fine, ma'am. Yes.
Okay. And is it understandable for you all?
Yes, ma'am. You are explaining in a very simplified manner.
Okay, thank you. I'm glad to hear that. So we all think that soft tissue sarcoma radiation therapy is simple. No, it is not. There are radiation associated complications. One complication that we rarely talk about is radiation associated pathological fractures, because the bone in the immediate vicinity of the radiation therapy becomes weak and fragile. And the overall incidence of this pathological fractures is very low. It ranges from 1.2 to 6.4%. And there are various risk factors which determine who will be at a higher risk of getting these fractures. For example, older patient will have a higher risk of fracture as opposed to younger patient. Women generally have weaker bones. They have more osteoporosis. So women have a higher risk of getting pathological fractures. Upper limb tumors will have a lesser incidence of pathological fractures. Lower limb or the weight-bearing bones have a higher risk of pathological fractures. Patients who've had periosteal stripping as a part of surgical excision to get the clear margins are at a higher risk of pathological fractures. So we must, look at all this information. Now, if the periosteal stripping is done for a smaller area, then the risk is lesser. If it is done for a wider area, then the risk is higher. The radiation dose also matters. There is a 10% risk for a dose of 60 to 66 gray, while there's only a 2% risk when we are giving a preoperative dose of 50 gray or when we are combining EBRT and brachytherapy. If you are doing the circumferential irradiation of bone, then the risk factor for fracture is higher. And with the use of chemotherapy, also the risk of pathological fracture increases. There are several mechanisms of radiation-induced fractures. One is that radiation-induced vascular fibrosis. So the vascularity of the bone decreases. There is impairment of osteoblastic cell regeneration. There is some amount of bone atrophy, avascular necrosis. So all these factors actually contribute to the radiation-associated fractures in these patients. Now, how do we manage these radiation-induced fractures? The management of radiation-associated pathological fractures is very difficult because the bone is already weak and fragile. And even when some fixation is done, they are very prone to having a lot of malunion. And the surgical fixation of these fractures is not very easy. So what is important is preventing these fractures. Now, how can we prevent these fractures? These fractures can be prevented by two ways. One is prophylactic intramedullary nailing for high-risk patients. So when your surgical oncologist is doing wide local excision of the soft tissue sarcoma, that time itself, one can do prophylactic intramedullary nailing. Now, who will be those high-risk patients? So for example, suppose I have a patient who's a 70 years old, diabetic woman, who's obese, who already has a osteoporosis, and has a sarcoma of soft tissue sarcoma of lower limb, for me, that patient will be a high risk patient, especially when the tumor size is large, when I'm going to irradiate a lot of area, and when the tumor is deep seated, and the surgeon will require to do a lot of periosteal stripping. So these are the patients who should have a prophylactic intramedullary nailing to prevent this fracture. So there is this study which which was published in 2010, where it was conducted between 1986 to 2006, and there were 22 patients who were treated with surgery and postoperatively developed pathological fracture. This study showed that the median time to develop pathological fracture is about 4 years. 70% fractures occur within 5 years. And the fractures which are developing in radiation field are associated with minimal energy. So this is the number of patients and this is the year of fracture. And as you can see here, that the maximum fractures have occurred in 4 to 5 years after completion of surgery and radiation therapy. There is a very interesting nomogram which is available to predict the risk of radiation associated fractures, which includes all the factors which I have just mentioned to you. For example, gender of the patient. So females have a higher risk. Age at the time of surgery, older patients have a higher risk. Whether the surgery is in the anterior compartment, they have a higher risk as compared to posterior compartment. Larger tumor have a higher risk. High radiation doses, periosteal strippings. So by combining all these points, you can calculate the probability of fracture and try and prevent these patients from the development of this fracture. Now, this is another very important study which came from University of Milano. This is by Edgar and Joseph, where they included 131 patients who have soft tissue sarcomas of proximal lower limb who were treated with wide local excision and radiation therapy, and 4% patients developed a pathological fracture. Now, 3 fractures were at the femoral neck and 1 patient developed a fracture in the subtrochanteric region. So we must learn to identify these areas. For example, this is the head, this is the neck, this is intertrochanteric region, and this is subtrochanteric region. So out of 4 fractures, 3 fractures occurred in the neck of the femur and 1 fracture occurred in the subtrochanteric region. And this is a X-ray which is showing the nailing which was done for fixation of this fracture. So in this study, when they did a 3D calculation of the doses of radiation which were going to the neck of the femur as well as to the subtrochanteric regions where the fractures develop, they have recommended that we must keep the mean femoral neck dose of less than 40 gray. And the volume which is receiving 40 gray to the femur or the bone should be kept as less than 64%. So when I'm treating these patients of proximal part of the lower extremity of soft tissue sarcoma with postoperative radiation therapy, I have recently now started contouring various parts of the femur, head, neck, trochanter separately to look at these doses, and I find that they are pretty useful. So far I have talked about when to give radiation therapy, preoperative, postoperative, timing of radiation therapy. I have talked about doses of radiation therapy, brachytherapy in brief, and volumes and margins of radiation therapy which are required. Now I'm coming to the second part of my presentation, which is only about brachytherapy. So I have 30 more slides to show. If you are okay, then I will continue. And if you want this class to continue tomorrow, because it has been almost an hour, then I can do it tomorrow also.
So should we postpone it tomorrow, ma'am, for tomorrow?
Yeah, I am okay with that.
Okay. So,
but let's ask, whatever questions are till whatever we've discussed so far.
Okay. So questions tomorrow, ma'am, or today only? For today?
As per you.
Okay. So if there is any question, please you can put in the chat box or you can unmute and ask also.
Yes, I'm okay with that also.
Ma'am, one question is that why is the preoperative dose less and why is the postoperative dose more? Is there any rationale or is it?
So a lot of these things have just developed out of results. For example, when you're giving preoperative radiation therapy, we want to just shrink the tumor and sterilize the immediate vicinity of the tumor. We know that surgical excision is still going to occur, is going to still happen. And as radiation oncologists, we were very conscientious that if we give higher doses and if the complications increase, then we will not be able to justify or promote use of preoperative radiation therapy. And in this randomized trial, they have clearly shown that the local control rate were exactly similar with a 50 gray of preoperative dose as compared to postoperative dose of 60 to 66 gray. Another possible reason for the use of lesser doses, here in preoperative setting, you can exactly see your tumor. While in postoperative bed, it is difficult to identify. You can never be as sure as you are in the preoperative setting. The third reason, possible reason, is that the preoperative tumor bed is a very well vascularized tumor bed. So probably 50 gray is enough. While in the postoperative setting, it is a relatively hypoxic bed. However, all these answers are very hypothetical. This is a guesswork. 50 gray worked, so it worked finally. So someone is asking, what are the dose constraints which are prescribed to the strip of the limb to be saved? So there are no hard constraints, or there is no volumetric data which is available. When we do contouring, when we do conformal radiation therapy in our setting, we try to keep a mean dose of less than 10 to 15 gray. When we are giving a dose of 60 gray, we try to keep a dose of 10 to 15 gray for the lymphatic corridor. And when we are doing contouring, we actually contour lymphatic corridor. The other thing which I forgot to mention was that unlike other malignancies, for example, suppose you're treating a head and neck cancer, you will use VMAT. Even if you're not using a VMAT, you will put beams all across. Your beams will be circumferential. But if you look at the IMRT studies of soft tissue sarcomas, generally 5 to 7 beams are used. Generally, even VMAT is not used because you orient your beams around your tumor bed only. You don't want to give beams from all sides, because if you're giving beams from all sides, sometimes it gets very difficult to spare the lymphatic corridor, especially the low dose wash will certainly be there in the lymphatic corridor. So even when we are contouring that lymphatic corridor, we tell our physicist that you have to avoid beams passing through this lymphatic corridor. You have to make sure that the opposite limb is not getting any dose. In IMRT, when we are positioning the patient, the positioning is kept more simpler as compared to conventional RT. For example, suppose I'm treating a soft tissue sarcoma of medial aspect of thigh with conventional APPA fields, then I will probably abduct the hip and flex the knee. But when I'm doing IMRT, the limb to be treated, I would generally try to keep as straight as possible, while I would try to move away the limb which is with the opposite limb to avoid any kind of setup errors. In IMRT, you try to keep the setup more simplistic for the limb to be treated. You try to move away the limb which is not to be irradiated. While in conventional RT, you are always positioning or aligning the limb which has to be treated. That is the difference.
Ma'am, what should be the timing of surgery after preoperative radiotherapy?
So generally, it is recommended as per the trial, NCI trial, it is recommended to do surgery at 6 weeks after completion of radiation therapy.
And ma'am, can we use brachytherapy for preoperative radiotherapy compared to only EBRT as we generally
There is
use?
no clear evidence for that. And soft tissue sarcoma brachytherapy, in the absence of open surgical site preoperatively, would be very, very challenging, as I understand it. Because imagine you're doing a brachytherapy in a preoperative setting in a closed wound, and how will you identify the vessels, etc.? Femoral vessels are running there, nerves are running there. How will you identify? Doing preoperative or closed cavity brachytherapy in breast is much simpler because you do not have any major vessels traversing that area. In soft tissue sarcoma, to my knowledge, there is no evidence or reported literature on that. As a radiation oncologist, I find it very gratifying to use preoperative radiation therapy. I get that chance very less. Most often, a surgical oncologist would be willing to do upfront surgery and send these patients for postoperative radiation therapy despite MDT discussion. But whenever I have done preoperative radiation therapy, I have found it very gratifying. For example, 4-5 years back, one of our surgical oncologists showed me one young patient, and he said that the tumor is so deeply seated in the thigh and is abutting the bone so much that this patient would require amputation. I said, give us a chance. Let's do preoperative radiation therapy. So when I started preoperative radiation therapy, within 5 days of 5 fractions of radiation therapy, patient had a substantial decrease in his pain. He started driving his car on his own, and this was patient's experience. And after about 6 weeks gap, this patient got operated, and to everyone's surprise, this patient had a pathological complete response also. But he did have longer time period for wound healing as well as prolonged lymphedema. So in one of the arroys, I discussed this patient with one of the international faculty, Patrick Kuplin, who was here in India for arroy. I discussed my patient with him, and I shared with him that this patient had prolonged wound complication and lymphedema episode. So he told me that even they have a similar experience. And in one of the pilot studies, what they did was they asked the surgeon to plan the surgical incision while they were planning the preoperative radiation therapy, and they tried to underdose that area so that the wound complication rates after preoperative radiation therapy and surgery could be reduced, but that also did not work out well for them. So I think that issue is definitely there.
Okay. And one more thing, ma'am, you talked about that we have a wider area of radiotherapy in post-op cases because of this surgical scar. So is it necessary to include the scars in the post-op field? Because in pre-operative, we are giving a very low, but if we are sure of the margins that it was of the tumor bed.
So honestly, there are no correct answers for that. So as a radiation oncologist, I have never seen any scar recurrence in soft tissue sarcoma. We are told to chase the scar or put bolus around scar mainly in two sites. One is soft tissue sarcoma and the other is parotid tumors. In parotid tumor, I have seen one patient so far where there was a scar recurrence. In soft tissue sarcoma, traditionally the teaching has been to cover the scar site with the bolus, and probably because we have been following it, we've never seen any scar site recurrences. So what we generally do in our practice is that if suppose the tumor is measuring only 10 centimeter, and my whole field becomes 20 centimeter. But outside that also, if the scar is continuing to go out, then we do not chase it. But whatever scar can be chased within then 10 to 12 centimeter, 5 centimeter craniocaudal margin, we generally cover it. We still cover it. And international recommendations also talk about covering that. But I have also not seen any scar recurrences.
And ma'am, you also talked about that pathological fractures are more in the areas receiving low energy. So can you please explain?
Kilo voltage era, the fractures were more. Probably the radiation fields were much less conformal, and the dose absorbed in the bone was much more. Probably that is the reason that there were much more fractures in that time, in the low energy era.
Okay, ma'am. So are there any other questions? Please unmute yourself, or you can also put in the chat box. So, ma'am, I think there are no more questions. So we'll see you tomorrow, ma'am. And I'm really thankful that you spent your precious time to educate us.
Yeah, I am also equally thankful to all of you for